Welcome, everyone. I guess I wonder what it's like when you start grand rounds with a bunch of rhetorical questions, but here goes. My name is Descartes Lee. I'm the Vice Chair for Medical Education, and I'm thrilled to be able to introduce our grand round speaker for this morning. First, I just want to comment a little bit about thinking about what it was like in our medical training when we all felt that disconnect between the focus on like the medical model that we're all trained to do and the complex realities that our patients' mental health and their lives are in. And how often we've grappled with the stigma surrounding mental health and mental illness in public and in the medical field at large, in our patients and even within ourselves. So sometimes I hope we can think about a healthcare system where mental health is seamlessly integrated into every aspect of patient care, a care system where the stigma of mental illness is replaced by empathy. So as mental health professionals, I think we all share a passion for unraveling the complexities of the human mind, but also for advocating for compassionate mental health care. I recently had the privilege of reading a very powerful book called Facing the Unseen, The Struggle to Center Mental Health in America. I thought the book's insights into the systemic challenges and biases that hinder our profession really resonated with me and came from a very personal and unique point of view. I thought the author's unique perspective as both a physician and a Black man in America added a really crucial layer to this conversation. The book reminded me that the struggle for mental health equity is linked to our fight for social justice. So our speaker today is the author of this book, and he's also a graduate of Duke School of Medicine, after which he went to Yale Law School. If you can't beat him, join him, I guess. But we were fortunate that he went back to do his psychiatry residency at Duke, where he is now professor of psychiatry and primarily stationed at the Durham VA Health Care System. He has won multiple awards, including most recently the National Alliance of Mental Illness 2024 Exemplary Psychiatrist Award. He also won Duke's Leonard Toe Humanism in Medicine Award and the American Psychiatric Association Solomon Carter Fuller Award. I mentioned his second book, Facing the Unseen, just a moment ago, which came out in April 2024, so very recent. His first book, A Black Man in a White Coat, was recommended reading by Oprah's Book Club and Entertainment Weekly, and was also selected as one of the top 10 nonfiction books by Time Magazine. So I'm very excited, and please join me in welcoming Dr. Damon Tweedy as he shares his lessons learned. Thank you.
Thank you. Wow, that's a nice introduction. Now I feel like I gotta somehow live up to that. Wow, who's that person you were talking about? All right, so thank you. Where's the clip? All right, thanks everyone for coming out on a Thursday morning. Tuesday. Wow, alert and oriented times too, right? Yeah, that trip yesterday from I was flying from Raleigh, and God, the cabin pressure when I was coming down gave me this the worst pain that I'd had experienced, and so my voice is a little off today too. So is there an ENT in the house? I guess I'm the wrong audience, but yeah. So but thank you for all for coming out. Yeah, really appreciate it. I'm really excited. I'll be here for a couple of days. Really excited to be here and meet everyone and talk. So basically, yeah, I kind of have three part-time jobs. It feels like 50-50-50. It's a lot. And so yeah, I'm a psychiatrist and I work at the VA part-time, and that's an integrated primary care mental health model. We'll talk about that later. At Duke, I teach medical students. We're going to talk about one of the classes where I teach medical students. It's sort of a kind of a somewhat hopefully innovative way of thinking about introducing students to psychiatry. I'm also involved in their it's like a ethics, bioethics, humanities program. This is not the focus of this particular talk, but I do have we worked on a podcast, which is like a history of medicine, race in medicine, looking at Duke through the era of segregation to the present, focusing on a specific case from back in the era of segregation. It's a really fascinating topic, and it's we turned into a podcast, 7-episode series that'll be coming out next month. So I'm really excited about that as well. And then I'm also the third job is this sort of writing and talking about medicine, race, mental health. And that's kind of what, obviously has brought me here today. So I'm really excited to be here and share some of my thoughts with you. Am I good with the volume back here? Am I good with volume? Sometimes I get really, as you might notice now, my pace is a little slow, I guess, but I can get really like animated and excited about these topics when I'm really passionate about it. And so I might get a little bit too fast. And if it feels like I need to slow or can't quite make it something out, just let me know, because I can get really into this. I'm really passionate about, these topics we're going to be talking about. So disclosures, I gave a talk last year and this year related to race and medicine. Certainly not discussing any unlabeled, unapproved use of drugs or products. I don't even know what those guys make, honestly, so that's probably bad, but I don't even know what they produce, so certainly won't be talking about anything like that. What we will be talking about today, really wanted to really talk about, really hammer home that sort of the divide between physical health and mental health, and that certainly I was indoctrinated into, and how that's really harmful to the patients that we see. The second objective is kind of related to the first. It's going to focus more on the African-American patient experience and how much more likely within the mental health world, you see such really disparate outcomes. Going to describe a couple cases from my own training that really underscore that. And then thirdly, really talking about, how can we improve the centering of mental health within medical education and practice? Like, what can we do to make things better? So one of it is like, how do we get here to this problem? Because, certainly after COVID, you hear people talk about this mental health crisis, mental health problem. And it's like, well, it's been going for a while. And so COVID really kind of just accelerated these issues. So how do we get here? And then sort of how do we move forward in our own sort of way? And so I'm going to tell you about ways that I've tried to move forward. And I'd love to hear from the audience, ways in which you maybe have done things. Because, part of what I love about traveling and meeting people is learning about new places, new experiences, different insights. In some ways, things are similar from one place to another, but also they're very, very different as you learn and travel. Okay, so this is a little different, unusual. So, I'm a writer, a medical writer. And so just a couple slides, how did I even get to that place? As a medical student, I was really hardcore pre-med, wanted to become a cardiologist, an orthopedic surgeon, I was a biology major in college, was only sort of focused on that kind of world. Got to medical school and, back in the day, our medical library actually had the physical copies of the journals. Now they don't have that, it's all electronic. It's like, what happened? And you could hold the copy in your hand. I feel like an old person saying that now. And I remember one day just going into there and perusing like one of the JAMA issues. And, rather than like talking about the latest study on, this heart failure, beta blocker, or this latest antidepressant, it was just an essay written by a physician about, their experience working with a patient in the clinic. And it just like, wow, this is really kind of resonated with me. It's like someone could write in 750 words or 1,000 words, something that really could capture the essence of what it was like to be what I was doing. And that really kind of just started me on this journey where, JAMA had a long section, a piece of my mind where they would do these essays. And Annals of Internal Medicine also has a section called On Being a Doctor. And I had the great fortune of being published in both in 2012. After years and years and years of even sort of thinking about writing, these sort of writing about my experiences. And both of those essays ended up in my first book because they're both rooted in the race and medicine theme. And both those essays ended in my first book. And that really got me on the path of thinking about, writing something bigger. And I never thought about writing a book initially, but those experiences really kind of got me on that path. And so just as one quick slide on this. So my book is there on the left, but I didn't just, I owe a gratitude to a lot of other people out there. And these are some of the well-known authors. Some are probably more well-known to you than others, but these are some of the books that really kind of inspired me to think about writing about medicine in a broader way. These books, despite, I actually know some of the authors here now, a lot of respect for them. They didn't talk about race in medicine in the way that I experienced it. So part of what motivated me to write my book was like, gee, I wanted to write a book that really touched on this experience. Like, I'm in a hospital when half the patients are Black and there's this complicated history and nobody's talking about it. And what is it like for me to sort of navigate that space? And so that was really the sort of the theme of the crux of my first book. But just wanted to sort of put that out there. Now we can move on to psychiatry. As you alluded to in the introduction, I feel like there's definitely some parallels between my journey with race and the challenges historically in our country with how we've navigated or failed to navigate our racial conflict, and also how we've dealt with the mental health issues. There's some parallels. And so the title of my book actually comes from this quote from James Baldwin it's like a 1962 essay in the New York Times talking about the state of race relations in the US at the time. And he said the following towards the end: not everything that is faced can be changed, but nothing can be changed until it is faced. That's certainly a true statement when we think about our racial history. And like, you can't change that, slavery and segregation and Jim Crow happened, but how we move forward requires us to really sort of take an honest accounting of the impact of that and how we can move forward. I think there's some truth to that also when we think about our struggles with mental health and mental health challenges. And so what I'm going to do in the time we have is sort of talk to you about some, data and big picture stuff, but also my own personal journey. Because I came to, as I mentioned earlier, I started in this field thinking in medicine that I was going to become a cardiologist or an orthopedic surgeon. Had sort of no real sense of I was part of the problem, to put it bluntly, of people who sort of look down on mental health problems, mental health patients, otherize them. I was part of the problem. And so now I'm coming to you as someone who's sort of perpetuated the stigma, and now I'm trying to sort of reduce the stigma. And so I feel like there's and then maybe some of you in the audience had a different journey, some had similar journeys, but I wanted to sort of put that out there before I dive into my own discussion here. So this is a Gallup poll from earlier this year. It's kind of a messy slide. The upshot is that people were asked, do you think mental health issues are identified, treated better, worse, or the same as physical health issues? So the orange and the red basically means worse. And so you can just see that there's a lot more orange and red on the slide than others. So for about 75% of US adults felt that way. You can see that there's some age distribution change. I mean, some difference. So the older people felt that was much worse than the younger population. Maybe there's some sense of how there's been a shift in how people sort of perceive mental health issues among generationally. So I think there's something there that's interesting. But there's still, the upshot is that there's definitely a larger perception that mental health issues are addressed in an inferior way. Now, some of that's access to treatment. Some of that's a lot of things that we'll talk about later. There's a lot of reasons why, but that's sort of the upshot. So I wanted to kind of tell you a little tale about my own sort of journey. So remember, I'm 50 years old. I guess that means middle-aged. I'm more comfortable with the idea that I'm mid-career. Okay, how about we put it that way? So I'm mid-career. And so that means that, there are a lot of people out there who are younger than you, and I can see in the audience you're younger than me, who trained in a different time, and maybe some of what I'm saying is archaic. But there's a lot of folks who are my age and older in practice. In our experience, I'm going to give you a feel for what it was like and why do we have the problems that we have. And I think that in some ways my own experience can be instructive in that. So as I enter medical school, when you think about what does it mean to be a doctor, what settings are you in? And it's like, well, these big state-of-the-art hospitals and these, emergency rooms where all these things are happening, high tech, or like any sort of kind of traditional kind of standard medical clinic that we think of. This is what medicine is. This is where people get care. This is what it's all about. There's like this sort of technological kind of feel to it. This is our sort of currency, our data. I remember learning these things, being so excited about, being able to interpret, this information, seeing numbers, and be able to make a diagnosis and figuring out what the person's problem is. And so it was all. This is sort of the currency that we sort of are indoctrinated into. And this is sort of the the data, right? More of the data. As an aspiring cardiologist, initially, I really had a weird obsession with EKGs. I have to just admit here, really was really into the EKG thing. And so, but this is sort of the medical currency that we sort of, kind of are indoctrinated into thinking. And our treatments are like this, very sort of concrete surgery and things of that sort, right? Let's contrast that with how we were introduced to mental health issues. And so I want to give you my own personal feel. So in contrast to my surgery rotation was in, of course, at the main hospital. I did a family medicine rotation, which was in a nice community hospital, like a community clinic right outside the hospital. And then I did psychiatry. And on the first day, first of all, people were warning you, well, be careful when you go there. I'm at the state hospital, and we have to drive to a different county. So I'm not in my little orbit of Duke. I drive to across county lines, and the first thing you see is a sign saying, the prisons on the left, the juvenile detention centers on the right, and here's your psych hospital. And it's like, well, gee, what am I, what are we doing? Why are these folks like separated out in a sort of institutionalized sort of way? And so that was very much the introduction to psychiatry. There's also this sense of, several people that we saw were in the justice system. And so there's this idea that everything's kind of different and separate from medicine. And so that's one end of psychiatry that I was introduced to. The other end of psychiatry was that I would hear stories about people being able to see psychiatrists in private practice and, in these exclusive settings, or there's all this money that you have to pay. And so this whole idea was that psychiatry wasn't something that was ready, accessible for the typical person. It's either for people who are, institutionalized, separated from society, or people who are sort of super well off, but not like, what about the everyday average person like the kind of world that I came from, right? And so how could we get care? And so that was sort of my introduction to the field. And, I didn't know what to make of it. Like you had to interview patients, and that was the data you got. And there's this thing called collateral that I learned about. Like, what is that? And I remember just being on my psychiatry clerkship, the last day of the rotation, I had to do the oral exam. I don't know if you guys do this now, but we had to interview a patient you'd never met before in front of a faculty member who you also had never met before. And it was this 30-minute interview, and you have to get all the data, and they come up with a differential. And I just remember really not doing a good job of that. The patient was talking very slow. He couldn't give me the data that I wanted. I got looking at the clock. How am I going to get this information? I'm going to look like a fool here. I got to get through this. I got to get through this. He's talking very slowly. I talk very fast, as you can tell, not oil and water. And so I ended up cutting this guy off to try and get the data. And then at the end, a faculty member, someone like yourself, I'm just trying to put myself back in that space. He's like, "So Damon, what do you want to do with your life?" So that's probably like a bad sign. I didn't really think about it at the point. Like, "Oh yeah, I want to be an orthopedic surgeon or a cardiologist." He's like, "Well, those are good fields, but you actually have to talk to people if you work in those fields. And based on what I've seen today, I'm a little concerned about that. And maybe you should do pathology." I was like, "Ooh." So yeah, that was my introduction to psychiatry. So wow. So yeah, so you can just sort of see that was sort of how it kind of flowed. So I always tell people, first impressions aren't always the last impression. That's my story there. But anyway, and then even the psychiatry, the treatments, like I know I was at the state hospital, and then they were still doing some long-term psychotherapy, and they were doing these different ECT, and it's like, what does all this mean? And so it was really hard for me to make sense of it as a trainee. And this is the kind of language that people trafficked in when I was a medical student. When people talked about mental health patients, I know some of these terms they seem so antiquated and archaic, but there was some of this language and like, "Oh, that's the crazy person down the hall. Don't spend too much time with that person." And that was sort of the language that people trafficked in, and you'd hear it and wacky and this sort of thing. And I'm not saying that I was like the person saying it, but I certainly wasn't challenging. And so that was the world in which you sort of lived. It was this sort of otherizing of people that we would see in that space. And so what happened? I've sort of told you how I was this other side of things. How did I begin to think about mental health in a different way? Now there were several things, but I would think the one that sort of stands out the most for me is, so I was a medical intern. I started out as a medical intern, internal medicine, categorical, planning to sort of do that 3-year internship and then go into cardiology. That was the plan. And then during that first year, one day I got called down to see a patient in the ED for medical clearance. You guys know that whole thing where we have to admit this person to our medical team overnight for medical clearance and then transfer them to psych or something to that effect. And make sure. And so the person was, quote, acting crazy, and make sure it wasn't a tumor, it wasn't whatever, infection, etc. And I just remember going down to the ED and seeing this person and just stopped in my tracks because I actually recognized this. It was a young gentleman, and I recognized him. And I'd seen him. I'd known him years earlier as an undergraduate student, and we played basketball together and some kind of intramural kind of stuff. And it was like, wow, what's going on? Why is he here? What could he be doing here? And then I just got stopped in my tracks. And then as I just because if you have to think about where I was up to that point, people may take it for granted, but see, up until that point, I had sort of think about my state hospital experience. By the time you see someone in that state hospital, they've already been down a path. They're already pretty ill. There's a way to sort of separate yourself from that person and from their, in some ways, separate that. And I think it's a big problem society-wide from that person from having the same full human experience that you may have. And so, like even today, I came here and you see the people here on the street are homeless, and you see people who are sort of clearly have a lot of distress. And it's very easy to otherize people in that way. We still do that in society. And seeing that in that moment was, it kind of caused this dissonance. I'm like, wow, I knew this person as a guy who was really smart. He's a basketball player. He's going to go to law school. He's going to go to politics. And now he's this. And how could this be? And it just really kind of just totally upended my whole sense of thinking about, illness and wellness and how those lines could be blurred and sort of kind of crack. And it was really sort of a really eye-opening experience for me. Because up until that point, I had no sense of mental health issues. I can tell you, we can talk more about my own personal journey with that. I come from a family So I come from a very sort of blue collar, working class, first generation college, Black family. Mental illness is not something anyone ever talked about or even conceived of as a thing. I have an aunt who, looking back now, she's deceased now. Looking back, we would in our audience would call her someone who has panic disorder and major depressive disorder. That's what we would say. She would have these attacks and she would kind of be reclusive. But what my family said is that she just had a strange way about her, and there was no sense that there was anything that was like, it was like characterological. There's nothing that was any sense that anything that any sort of person in a medical world could ever do anything about. And that was the context in which how I was, thought about that. Even had a neighbor who I'm pretty sure had schizophrenia. She had some really unusual episodes. People just said, "Oh, she's just something else." But no one ever conceived of it as anything more than that. And that was sort of the world in which I grew up. So to see this was like eye-opening and just mind-blowing to actually see that. So of course, as you begin to see that, you begin to see that the world it opens up in a whole different way. So in the medical world, we would get people all the time who had an overdose. Someone's overdosed on. I saw a college student who overdosed on Tylenol, a law student who would cut her wrist, someone else who had taken some other kind of overdose. On the medical side, you see them after they've attempted suicide in some form. Previously, I would have never sort of thought about them much more than just the medical side. But then I began to try and engage and connect with people in a different way. And this is all happening while I was a medical intern. And that's sort of how the process started. And I began to see how prevalent mental health issues were. This is a sort of a generic slide to your left there, showing the prevalence of different mental health disorders. But I also began to see it in our own group of folks, in our own field, and that was also something I didn't think about. There's a lot of talk now about physician wellness and mental health issues among providers. But in the book, I describe a chapter, describe a scenario where, as a medical intern, there was another intern in our cohort, and one night I was on call with her, and she just like kept paging me repeatedly, and we were just like, oh, "What's her deal? Like, why is she doing that? Like, I already told you the answer." And it was like this very sort of just repetitive, sort of compulsive kind of thing. And I remember mentioning it to a couple colleagues, and oh yeah, she's just kind of weird, and that was that. And it's like no one even thought about, could this be a sign that there was something amiss, right? It was never even a consideration. Thought never once crossed our minds that there could have been something else amiss. And several months later, she ended up I guess I don't know all the details, but she ended up having to leave the program because something happened with her and a patient where I guess her obsessive compulsive kind of tendencies kind of caused some problem. Nothing's too severe, but something to the effect that she couldn't continue in the program. It's really sad, right? But it was really, I'm just struck by the idea that we never even considered, never even crossed our minds that something could have been amiss. Like if she'd had some sort of limping or some sort of physical illogical symptom, we would have just been attuned, man, you should get that checked out. We never even crossed our minds. And it's just sort of think about kind of, where we were at the time. And then, and years later, I learned that I was giving a talk actually at Johns Hopkins, and it's like 2016, and I ran to someone who knew someone I went to medical school with. And she said, "Oh yeah, do you know so and so?" "Yeah, of course I know him." I said, "Well, what's he doing now?" She told me he died from suicide. I was like, wow, how could that have happened? We spent so much time together in med school. It just like the idea that he could have been struggling was just such a disconnect in the way that so many of us were trained in indoctrination. I know things have changed a lot now, but I wanted to give you a feel for why do we have these problems? How do we get to this place? And it was these sorts of experiences, I think, in the way in which we've been brought to think about mental health issues that led us to the problems that we have today. So among our patients, but also amongst ourselves. So, for this audience, this is all kind of nothing to earth shattering. But suicide, of course, again, as we talk about how these mental health issues are nebulous, like how do you diagnose this condition or that condition, and it's not tangible in the way that these numbers that I showed you earlier. But gosh, suicide's extremely tangible, right? What's more tangible than that? Every year, 10th or 11th leading cause of death. You can see the numbers. So I like this slide because it kind of shows you when I started medical school. So I finished med school in 2000, and you can just sort of see that sort of upward uptick of suicide completion from when I started finished medical school to where we are today, about 35% increase. But suicide only captures one big part of the larger puzzles, because for every person who dies from suicide, how many people are we seeing in emergency departments or hospitals who attempted suicide? And how many people we don't even know about, right? So a couple of weeks ago, I saw a guy in the clinic who had an outpatient clinic. A couple months later, I saw a guy in the outpatient clinic. He was seeing his primary care doctor, and apparently 2-3 months earlier, he had overdosed. He'd taken like 25 clonazepam tablets, just went to sleep for a couple of days, no one even knew about it, right? So these are the kind of ones that are unreported. There's so many situations like that. So every suicide death, there's so many more things that are out there that we sort of, again, this audience knows that. I don't need to sort of share it to the audience, but sometimes I got to lose. Remember, you guys know this stuff. But a lot of folks that I talk to, because most of the people I actually talk to are non-psychiatrists actually, and so for this sort of thing, these kind of information is really eye-opening for them to really see and express. You guys know this. What are the problems? What are the challenges? I've talked a lot about these issues. We'll talk a little bit more about the system problems on the back end. I'm curious to hear from the audience kind of how what it's like out here compared to what it's like where I'm at, but I'm sure there's certainly a lot of similarities. But again, I was certainly one who contributed to the stigma myself. One thing I didn't tell you about, that I should tell you about, when I was an intern, I told you about the physician mental health problems. So I was someone who was thought of myself as very psychologically healthy. My wife might disagree. That was a Josie joke. Gosh, that was flat. Anyway, so yeah, I was someone who thought of myself pretty, robust. Like in terms of like growing up, I may have cried after I was a kid, maybe a couple times I could ever think of. One time in high school, we lost a basketball game in the playoffs. That was really emotional for me. My grandmother died when I was a medical student. That was emotional for me. Other than that, nothing. Like I'd never seen my dad cry. I'd never seen my brother cry. That's the kind of world that, my mom, I maybe see mom cry once or twice, her mom died. And that was sort of the world that I grew up in. Very sort of that's not the, which it's not that sort of thing. And so there was one day as an intern that it was just stress had really kind of caught up to me. And I remember I was trying to do this paracentesis on this guy who had ascites, and I couldn't get it to work. I was pretty good with my hands with procedures, but for some reason I couldn't get this to work, and I got really frustrated. And I thought I swore under my breath, but I guess it wasn't under my breath. And the resident's like, "You can't do that. Like this isn't anesthesiology where the patient's asleep. You can't do that." And so, and then I remember like getting into the call room and kind of just getting really upset and like swung my board across the room, which is me and a medical student. And the medical student was like comforting me. It was really bizarre. Like this is really upended. He's like, "It's okay. My sister's an intern. I know it's really stressful." I'm like, "Wow, this is really backwards." And so the next day I went to see the chief. I saw the chief resident just because I figured, well, someone else might get out. I'm just kind of worried. And the chief resident, he started using this language like, "Well, I'm worried about you, and maybe you should go see someone in employee health." And I was like, "What is he talking about?" And and then I realized the more I protested it, maybe the more I might seem like there's something wrong. And so I ended up going to see this person in student, what do you call it? Employee assistance, EAP. And this was eye-opening for me. This is an eye-opening experience because, at that point, I'd never seen anyone in the mental health field ever. I never. You kind of got that feel for me, right? Really closed off to this whole thing. This is me as a medical intern. And so on that particular day, I'm not sure why I was dressed the way I was, but I know it was cold and I had on a sweatshirt. And I remember putting the hood over my head as I walked into the room because I felt such like embarrassment to go into the room and into this clinic and be seen. But then, of course, I realized I'm a really tall Black guy. If I walk into this place with a hood on my head, I don't know, this might go another direction. So I'm gonna, go along with things. But I went in there, and I remember there was this kind of shame that I had, and I saw this social worker, LCSW, and it was at that moment that I realized the vulnerability that the patients that we see can have. Because I walked in there, and I realized in that moment that I had worked so hard to get to this place. Think about my family and the journey they had. And that this person maybe could like take it away, right? I didn't know what he might think. He might think I'm unfit to return to work and like I could lose everything. And it just made me realize the vulnerability that patients experience when they go see a doctor. Because as you're an intern, sometimes you feel like the world is beating on you and everything's against you and you're the victim. And then you realize in that moment that wow, the power that you really can carry with you in that moment. And you have to hold on to that. And so that was really an eye-opening experience for me to really begin to think about it. In the end, it was just like I was just stressed for a couple of days, and it wasn't a long-term issue. But even in that moment, for him to be able to help me normalize that was such a powerful thing to be able to realize that. So that was I just wanted to kind of make sure I brought that up. So anyway, these are things that people probably, again, this audience knows about this. It's hard to see someone, right, mental health therapist, psychiatrist, prescriber, whatever, compared to other medical fields, right? And we know that, right? We've all seen that. ProPublica put something out recently. I don't know if anyone saw that about the insurance and the ghost networks. It was pretty powerful story they put out over the weekend. If anyone wants to see that, but again, this audience, this is not going to be new stuff. So again, out of network insurance still doesn't cover it. Again, this audience knows that the challenges. I'm curious to hear people's perspective on why this is so, though. I'd love to hear people's their own thoughts about that. A lot of reasons, I think. So in a nutshell is that we have this world of physical health and mental health being divided, right? You know, the general medical ward, like just in clinics I work in, like in that one hospital, the primary care general medical, all the medical clinics on the first floor. You know, the general medical clinics, the subspecialty clinics, all on the first floor. And then the mental health clinic is in the basement in the very back. And it's like, what are the kind of messages that even sort of convey the way we even set things up? It's just things that are just like, I mean, these sort of things, like, what are we saying to patients? Oh, here you get all your medical care, and here if you got this mental health problem, you got to go all the way to the basement in the back, where no one can really see you, know you. It feels like some kind of sobering thing to think about. In mental health, there's this really powerful sort of public versus private distinction that we just talked about with the insurance. And I wanted to tell you a couple stories. They're pretty, you know, not pleasant stories, but I wonder what these have happened here. And do any of these resonate with you? But these are things that are really powerful when I was experiencing these things. I wonder what they would be like here. So one day I was in the ER. This is me as a psychiatry resident at this point, and two women came with pretty similar types of problems that we would see commonly in emergency acute psych. Because of the shortfall in outpatient care, which is a separate conversation, the nutshell is that both women needed short-term inpatient stabilization. Now, what happened though was very different. So the first patient had insurance. She was white, and so she was able to go to the sort of inpatient kind of, you know, private / university unit where you need to have your own room. You get daily psychiatry visits. You get some psychotherapy. No one wants to be in a place like that, but it's obviously under the best circumstances, the best place for a person in her situation. And even how she got there, a nurse came from that unit downstairs and brought her upstairs and escorted her up like you would in a medical wing, right? But look what happened with patient. So patient B was uninsured. And gosh, I remember I had a faculty attending one day. He told me I was calling to present a patient. I started the story. He cut me off within like 3 sentences. He's like, man, what's her insurance? Like, didn't even care about the medical, the psychiatric aspect, because the insurance was going to drop everything that happened. And that's all he really needed to know. Sadly, he was right in some way. And so this person, we couldn't get her transferred to any of the other hospitals. And so all was left was a state hospital. And how does one get to one hospital to another? Now, I don't know if it's like that here. This is what I'm curious. I know this varies from state to state, but in North Carolina, the only way that's going to happen is no ambulance is going to do it. You have to get a police officer. And so you call the sheriff to bring someone from point A to point B. And this is a person who comes in voluntarily, not violent, nothing like that, just voluntarily coming in, but this is the outcome that has to happen. And you think about what that means for that person, right? This is your first encounter with the mental health system, and this is what happens, and how that may shape your future in all sorts of ways. And so this was a really sobering thing to experience. And for me, being on the end of it was really troubling because, you know, certainly, because someone might say they said like obviously had a racially disparate outcome, but it wasn't like a racist intent by the provider. So when people say systemic racism, the system sets things up, this to me is a really kind of powerful example of what that looked like. And I think this kind of underscores the larger challenges we historically see with African-American people in the mental health system. There's a lot of studies that show, you know, less outpatient care, more settings in the emergency room, inpatient, and involuntary treatment, the things that I was just highlighting there. Because we actually had to make her an involuntary patient, even though she was seeking care voluntarily, because the sheriffs wouldn't take her otherwise. So it was this whole sort of process of just like disempowering this person in a really terrible sort of way. And so that was just sort of the system, how it's been set up. Another example, and of course, it's not just race, because there's certainly other examples of people who get really the worst ends of things. And this is a case from, I was at the VA as a resident as well. A woman came in, she had been in Iraq, she'd had combat exposure. She'd also had a sexual assault while she was overseas. And she had been prescribed oxycodone after a car accident, and she'd recently escalated that to heroin. Now, that's a story people probably heard hundreds of times now. That was the first time I'd ever heard that story. This is before we sort of knew about what we call the opiate epidemic. First time I'd ever seen anything like this. And what did we offer her? Basically nothing. So buprenorphine was available, methadone was available, but no one even had an idea of how to talk about that, how to make that work. We just sent her home and said someone was going to call you in a couple of days. And I just wondered, like, you know, and so then some weeks later, I tried to call her, couldn't get through, and I just wondered kind of what happened, you know, because I mean, that was the system that we had at the time. And of course, now we see here, this is something we know a lot about, right? The opiate epidemic and how so look at 1999, 2000, when I was in medical school, finishing med school, you can see how it's escalated, right? And so it's just sort of this like kind of living history to sort of see and think about. So those are some really challenging issues. So I've laid out some really troubling issues, right? Societally and also, in terms of our field of mental health. But I wanted you to go back to that quote from James Baldwin. So what do we do with all this and how we begin to move forward? This is all kind of sobering, right? I hate that because I'm actually an optimistic person. I'm actually really sort of a positive person, and I know this things sound very sobering. And so I've tried how can I find space within this to sort of move forward and make a better of the world? So I'll give you a couple examples. So obviously in my clinical work, I work in this integrated care model, collaborative care. I'm in a mental health provider. I'm working in a primary care setting. I can't tell you how many times this has actually helped patients avoid sort of the worst. About a month ago or so, a primary care doctor was sending me a note through our system, and he was like, "There's this guy. He's crying. He won't stop crying. I'm gonna have to send him to the hospital." And even those things, I'm going to send him to the emergency room. I said, "No, let me just talk to the guy. Let me just come down." So I came down there, and maybe the guy was depressed. He was sad, but we talked for about 20 minutes. Came with a plan. Follow up in a couple of days, and I saved this guy an emergency department visit, and he's doing fine now. But it's just like these kinds of things happen all the time. The other thing that happens a lot in the sort of traditional model is that patients in our system would go in their primary care. They get a referral to mental health electronically, and about 40% of the time never comes together, never follows through. Maybe it's the patient, maybe it's the system. Who knows? Probably all the above, right? But one day there was a patient who I was able to see. He was an older Black guy, and he was really taken aback. He was like, "I'm never going to go see a psychiatrist," and I happened to be next door. And then suddenly he was really, he saw me. And we started talking about things, and had a great conversation. And he got better over time. And then several months after I first started seeing him, he confessed to me something that really unnerved me. He said, that first day, that was going to be it. Like he'd mapped out this extensive suicide plan. He'd mapped it all out. He happened to just have a scheduled primary care appointment. And he just went today. He's going to kind of say goodbye in his own sort of way. And guys maybe learn when you were in school or in training that how many people have appointments with doctors before they attempt suicide. Is pretty common. How commonly people are seen. And this guy had it all mapped out. He'd gotten stockpiled all these over-the-counter meds. He was going to go out on a boat and just fall out into the water. And so it looked like it was an accident. So no one would have thought it was a suicide. He just maybe had a heart attack and went in the water and drowned. He'd had all mapped out. And I know he kept insisting that I saved his life. I saved his life. I saved his life. If I hadn't been there that day, this never would have happened, because he would never would have gone to see a psychiatrist with a referral. He would never have gone through with that. And just the idea of being there on site in the moment, and how powerful that was for this gentleman. There are others as well. That was just the most powerful example that comes to mind. And so I've talked with some people who work in this field, particularly there's a guy in Colorado, and the University of Washington's kind of been a pioneer in this. And they're sort of advocating for the idea that we really need mental health in every layer of general medicine. So whether it's the diabetes clinic, the kidney, the transplant clinic, every area of medicine really needs this mental health overlay. Now, that's not a threat to us as psychiatrists, because there's always going to be a need for psychiatrists. We should know that. This is not a threat to us, but this is like, how do we actually deliver care in the way that people can access it and need it? And so this has been a really big part of my professional life and story. And then I'm also, as I mentioned, I teach medical students. And so I told you how the traditional medical school rotation that I had, we basically just, it was all inpatient. And that's kind of what it's like now mostly as well. So here's the issue with that. It's really important, of course, to know that. But I feel like in some ways that makes it conditions us. Now, maybe some of you will disagree with this vociferously, but I feel strongly that it conditions us to think about people with mental health problems only in one sort of way, only in a sense of crisis, only in a sense of distress, only in a sense of vulnerability. Only in kind of the worst sense of it, and that sort of conditions think about people in that sort of way. You see a label, and you think of the person, you think of that. You see schizophrenia, you think of that person you saw. So what I've tried to do in this course is kind of expand students' thoughts about what it's like to see people in the mental health field and to work out to the community. And so some of these are topics that you don't cover, like perinatal psychiatry. I don't know, I'm sure you guys have specialists here. I'm amazed to learn about how much the sort of maternal mortality disparities are rooted not in things like preeclampsia and diabetes and hemorrhage, but actually in mental health issues that are being unmet. There's some recent studies that came out in JAMA earlier this year that really sort of focus on that. Fascinating. So I have perinatal psychiatrists come and talk to us about that. We talk about integrated collaborative care, ped psych, geriatric psych, things that we don't necessarily cover. But then the real crux of the course is taking people out into the community. So I take the students out to the jail, the county jail, where you see how much mental health is delivered there, and they get to sort of see that for themselves. I take them to a methadone and buprenorphine clinic, take them to a clubhouse setting. I want to say more about the clubhouse thing in a minute. That's a really powerful thing. Who here kind of even knows what I'm talking about when I say the clubhouse model? So some, yeah, okay, good, but not everyone. I wanted to tell you about that because I never knew about it before. But I wanted to tell you about that. It was a really powerful story I want to really illustrate to you there. And then I'd also take them to a very swanky eating disorder program. It's got everything you could imagine. It's got the super, it's got all the partial hospitalization, IOP, outpatient. It's got the residential that people can stay 45 days. It's got all this. I mean, eating disorders are very serious. I'm not being taken light. It's very serious. But it's amazing the level of resources that they're able to receive there. And I want students to see that. Well, you see people that get care this way, and you see people in a jail. And in that jail, I mean, I don't know if you guys been inside of a jail, but that toilet in the jail, like down here, I just can't, I have bad knees. I can't even imagine ever even getting down to the toilet. Oh my gosh. People are just like out in the open. It's like, just imagine the level of like sort of how people are, and this is a jail. So some of these people are not even convicted. This is pre-trial. They haven't even been convicted of anything, right? And you see the disparities. I want people to just really see that for themselves. And I've had several students tell me that, they've gone to college now and they take all these courses on social justice, et cetera. But they said they actually learn more just going to these clinics than about the social determinants of health than they ever did in any lecture anyone ever could tell them about. Just seeing that for themselves, what it actually looks like. And so that's been a really powerful experience for me to sort of get students out there. And it's helped them even begin to reframe mental health and psychiatry in a broader way. And I want to tell you that here in this next story. So the traditional model is you see people, again, in the hospital, in ER, distress, worst state. But that's just one particular part of a person's journey in life. So I had a student, he saw a woman on his inpatient psychiatry rotation. She had either schizophrenia or schizoaffective disorder, very distressed, requiring, that all the usual sort of injectable medications and all this sort of stuff that we think about in the inpatient psych unit. And several months later, he was in this course, and just by happenstance, he sees the same woman just by happenstance at this clubhouse. So a clubhouse, these are sort of non-medical places where people can sort of get, resources to help them function in life. There's like vocational training, they focus on nutrition, they do, like a job skill, they do education, community. It's all non-medical, right? And so we have one of those in Durham, and they're really big into the gardening. So that's a really big theme of clubhouses. And so he saw this same woman in that setting, and she was very different. At this point, she had been several months outside the hospital. She was functioning in the community, and he just couldn't believe it. He just couldn't believe it. He said, I thought people with schizophrenia were only like what I saw in the hospital. No, there's a lot. This is not like some like meathead person. A lot of people feel that way. And I just couldn't believe it that I saw her like this. He wrote this wonderful essay about it. Now, he's not a psychiatrist. This is good. He's actually going to be some sort of internal medicine specialist. But I think it's great for doctors to be able to understand that and see that. And because when you see someone, a label on a chart, I see it all the time. They see this label, I get these calls. They see the label on the chart. Bipolar, oh my gosh, schizophrenia. I saw one time a doctor, this is a primary care clinic, a patient had a schizophrenia diagnosis. And this doctor was going to call the police. I was like, what's your evidence? Well, he's got schizophrenia and he's been involuntarily hospitalized before. She's going to call the police for this medical appointment. I said, you can't do that. And so again, I had to kind of intervene because you think about how medical doctors are educated. Like my wife is a primary care doctor. Her only experience in psychiatry was a 6-week inpatient hospital stay. I mean, in medical school. She got no training in residency. And now half the people she sees have mental health problems. And so it's like this incredible disconnect. So I don't think we're serving future non-psychiatrists well if we only focus on this sort of this acute care crisis approach to psychiatry. We need to get them to see people in a much more full way. And so this is kind of what I'm trying to do in this program. I hope that makes sense with you guys, because I mean, it's such a really powerful thing to be thinking about. She was going to call the police on this guy just because he had a label on his chart that says schizophrenia. It's like, what is wrong with you? And so, I mean, but that's the world in which we sort of kind of been with here. And so we got to change that narrative. And so this is me with some of my students. You can see the old guy, all around all these young people. So you know who I am. So these are some of the students that I've been working with over the years, and there's several more. These are just the most recent group of students that I've been working with. The first one on the left was after we'd gone to the methadone and Suboxone site visit, and after that we had ice cream together as a group. And the other one was after one of our other site visits as well. And so I think this is a really important part of like how do we think about psychiatry education in a different way. And I'm going to leave you with this sort of thing. We should have time for questions. Good. Good. You didn't have to even show. She was going to. She warned me. She's going to show me all these, like, about 2 minutes, 5 minutes. I was feeling the pressure. So anyway, here we go. So I want to leave you with this quote from Dr. King, because these challenges are powerful, right? They've been long-standing. They've been with us for a very, very long time, and it's not as if we're going to be able to change these things overnight. But what can we do? What do we do? What is your sphere of influence, and how can you begin to sort of affect change in your own way? And this quote just really sort of sticks with me. You cannot do great things. I can do small things in a great way. This is not from here to hear me to toot my horn, but I want you to just understand kind of how I see it and how my passion is trying to drive the next generation. So I'm really passionate about the idea that 95% of doctors are not going to be psychiatrists, but they're going to see so many people with mental health issues, and we've got to do better. We've got to find a better way for them to be thinking about patients and their full humanity and beyond the labels that we sort of think about and learn about in medical school. And this is all, and these students, this is all what kind of inspired me to write the current book. And so, contact information, website, email, Facebook. I haven't gotten Instagram yet. My kids say I should do that. I'm just so, I guess it's my age here. And then X, Twitter. The thing that I really enjoy the most from people is just getting feedback, because I know that my experience is just my experience. I'm not here to say I speak for all of you. I'd love to hear, your perspectives, experiences, your journeys. I guess that's a psychiatrist in me, right? So with that, I want to just kind of leave it open for questions. But again, I want you to think about that. What is your, so two things I want you to think about. So two things. So I've come here today, and if all I did today is come here and talk, and you just say, okay, this guy talked about this, that's sad or that's good, or whatever, moved on, then I don't feel like I've accomplished much. I really want you to be thinking about like what have I said that could connect with you in some way that you can think about moving forward in your own space. What can you use to in your own, whether it's talking among each other, and what are you doing? Maybe you're doing things better already, but what can you do to make things better in your professional lives, but also in your personal lives? I didn't talk much about my own personal journey, but there's a world of people out there who just need a little bit of guidance in ways that sometimes we don't recognize. Because I came here today as a person who's like, you see all these introductions like, who's he talking about? Because if you would ask me as a 14-year-old person, I would never have imagined that I could have been a doctor or that I could have written books. I was that kid who would, when a book was, my mom would say, you should read something. I was like, why would I read a book if I could watch it on TV or watch a movie? I'm not gonna read a book. Like, that's not, I was that kind of person. And so the idea that I'm writing books is hard for me to believe still to this day. But in middle school, I'm going off the script a little bit, but I'll stop. When I was in middle school, I think it's important for us to think about the world, though. The world we see and how we see people is so important. It's easy to see people as snapshots and of stereotypes. It's so easy to do that, and you lose so much. So as an 8th grader, I was in a lower performing school, but I was good with numbers, and I had I was into sports data and stuff like that even then. And a math teacher suggested I take a test to get into a STEM program, and I was categorically against that. I was like, there's no way I'm going to do that, because I'm going to be the only Black person in this group of students who are all white and Asians. No way I'm going to do that. This is amazing. This is the world that I lived in. So I'd already, by that point in my life, internalized that I wasn't as intelligent as people who were, white or Asian. I'd already internalized it. No one ever told me that, but it's just like you just suck it in. The air just sort of just sucks it into you, and you believe it. And so I said, no way I can do that. And she tried, and I said, no way I'm going to do that. And so a lot of times in the world, people will say, well, I tried to help you and you couldn't help yourself, and I'm going to give up. And that's the world we kind of live in many ways. And so what she did, and this is like a metaphor for like think about the world more broadly, is that she called my mom. So she was like wondering why would I do this? Like why would he do this? Does it make sense to me? So she called my mom and tried to explain to her. She called her on a Saturday morning, and I concealed it from my mother. And she was like, my mom was very blunt. She's like, boy, you're crazy. What are you doing? You're going to take this test. I had to take a standardized test to get into this program. So I took a standardized test, and I got into this program. And it was really opening of me thinking about how I can relate to the world in a different way. Because there's a world of people out there who just don't have a perspective on how they can relate to the world. They don't have the opportunities. And she really showed me a different way in which I can relate to the world. Because if you'd have told me as a 14-year-old that I could have been a doctor, it would have been inconceivable. Inconceivable. I mean, I would have thought, well, I probably had a better chance to be a football player, even though I'm afraid of getting tackled. But I would have probably thought that, just because that's what I saw. That's what the world showed me on television and everything, right? That's what you see. That's what you believe. And so it was a really eye-opening experience. And so once I got there, I began to see I could relate to the world in a different way. I had abilities I didn't know I had. And I think there's a world of people out there like that. And some of our patients are like that. Like some of our patients get written off. Alcoholic, drug addict, worthless. And can you see the humanity in that person? Can you see that person beyond where they are in this moment to what they might become. And so I want you to be able to think about that as you sort of get out there into your own world and your own spaces, and take a little bit of that, and then I feel like I would accomplish something here today. So thank you with your time.
Thank you so much. That was great. Really appreciate that. We have some time for questions. So anyone wanna?
What was that show? Come On Down. Is that Price is Right? I'm such a my kids are like, please don't embarrass us when you come to these places because you're so corny.
It's good exercise, right? Thank you so much. And I have a comment and then a question, but I'll start with the comment that it's actually the 100th year after the birth of James Baldwin, and
That's correct.
And that related somewhat to what you're talking about. He continues to be a very underappreciated, under-recognized genius, and that you know, France, from France, is actually making an effort to expose French people to his literature, because as you know, he lived in
He lived there.
France.
Yes.
Yeah, exactly.
Yeah, exactly.
That's one comment. Thank you.
Well, thank you.
The other thing is, how do you think about the potential, well, the obstacle, if you will, of you exposing medical students to seeing things that they don't see, and the fact that the vast majority of their teaching body is not going to necessarily emphasize these lessons, or is going to emphasize them in a way that is not necessarily owned at the level that you're providing. And like, have you thought about like how this issue needs to be addressed? Because it's not unique to Duke, right?
No, sure. Yeah. I mean, I've been expanding the course every year. And so now it's touching most of the students. It initially was a really just small little cohort, kind of more because people say, well, you're only preaching to the choir, right? And so certainly we've had some people who are definitely not that. And it was really an eye-opening experience for them to sort of see some of these things. Because some people are like, we went to jail, like, oh, everyone goes to jail is bad. I mean, I've had people sort of have that kind of, mentality, right? And sort of having that exposure it gives them a different way of seeing the world, thinking in the world. So I'm hoping to continue to expand it. So I guess I would say that. And so I'm hoping to talk and find out what other people are doing in other parts of the world, other medical schools, and see if there's different ways of doing it. But that's sort of my own effort to do it. But yeah, thank you. And thank you for the Baldwin reference as well. Yes.
Thanks for the wonderful talk. I just wanted to share an experience that I've had here. So I graduated from residency in 2018, and
young guy.
I just left this position, so after about 6 years. But my first job out of residency was working in the county jail, which actually our department took on as a academic practice.
Oh, okay.
So it actually created an opportunity, which was I've had longitudinal third-year medical students doing a longitudinal rotation with me in the jail. This was the third year. My medical students now joined me as I've transitioned to a community clinic. But it was an incredibly moving experience, I think, as an educator. And then I know from feedback I got from the students how moved they were by actually doing their entire psychiatry rotation. Because this longitudinal clerkship, when they were with me in the jail, that was the entirety of basically of their third-year psychiatry clerkship. And we see everything there, as you know, and also all the sort of structural inequities that really come to bear, and also the way psychiatry is really at the bottom.
Yes.
I had deputies in my work tell me, medical is here, psychiatry is here. I mean, that was the quiet part was out loud there.
Absolutely.
Often. So yeah, I just wanted to share that experience of actually having the jail be a place for education, and it's been one approach here. There are still, faculty psychiatrists there. We have residents and medical students there regularly. So I think it's obviously a difficult, structurally complicated thing to pull off, but it's been a really amazing experience here.
Right. Yeah. So as you mentioned, thanks for that comment. It's much more complicated to make these things work the way that it's easier to put someone into a psych unit and just leave them there for 6 weeks. It's easier, but it's much more complex to do this other sort of work. But I am a big proponent of there's cross-sectional education, medical education, and then there's sort of longitudinal medical education. I think you need both. And if it's only cross-sectional, I think you're going to be losing out. Even think about like something like OBGYN. Like you think about when you only see women when they're about to deliver the baby, and then you see this delivery, and then you're gone. But think about how different it is if you might see that woman when she's pregnant, and and you get to experience them to delivery, and then see them postpartum. It's a different sort of way of even thinking about medical stuff, right? And I think that's the challenge that I know it's much more difficult logistically, but that's the model that I think we need some blend of both. Yes. Hey, sir.
Hi, I'm Jack. I direct our mental health program for trans kids. And I was listening to your bio and like the brief mention of Yale Law School. And I'm always interested in the interface between medicine and law and health disparities. And I'm just curious to hear how you integrated that experience into your work and career, and if you have any lessons for us.
I do it academically. When I was so law school was part of the appeal was that there's so much in medicine that felt like it was missing so much. Like you see all these patients and there's like only this sort of clinical encounter, you're missing so much of like what's the big picture, how do we actually make change, how do we affect change? And that wasn't part of my medical education at all. So I was involved with some I'm from the DC area, involved in some social, like political kind of stuff, policy stuff. And so I've been involved with things to that degree, given some presentations to the members of the House and U.S. House and that sort of stuff. And so, but from a practical standpoint, it's mostly an academic thing where I teach. I got some work. I do some sort of medical legal stuff with law students, medical students, that sort of thing. But yeah. So it's sort of like an interesting kind of journey. It may be something that I get more back into once my kids get out of high school. I may get a little bit more into some of that work in a more direct way, because I'm really interested in certainly some of these issues are like us as doctors and providers, but some of these issues are much bigger, right? Much more, we got to affect change at a broader level. And I'm well aware that I'm really interested in that as well. So I'm thinking about getting back into that space before too long. So, yeah. Oh, okay. Oh, okay.
So the last question is from Carissa. It says, can you speak about patients recovered from a mental health diagnosis, but carry the diagnosis in chart? How can that person have equitable care with that judgment prior to interacting with a patient, such as a sober person with history of severe alcohol dependence?
Yeah, great question. I think one of the, if students are exposed, like take alcohol use, if students are only exposed to patients who have alcohol problems in detox, or they're in intoxication in the ER setting, which is important, of course, if that's all you see, that's kind of what you see, and that's what you think of when you think about people who have problems. But if you compare that experience with other experiences with people who have alcohol use problems who are doing well, or in recovery, whatever term you want to use, for years, it gives you a much fuller picture. So when you see that label, you don't automatically just associate that with negativity or with this sort of distress. And so I think that's what's important in the long run. Because now if I see that on a chart, it doesn't mean like I'm going to think I got a whole broader way of thinking about it. And so I think that's the key. But so I do think it's important. So I try and tell students, be curious, right? This person's had this issue of alcohol use, but there have been, not drinking for 10 to 12 years, learn more about it, take that experience with you, be curious, don't just assume the worst. But that takes a process. I mean, our system, has not historically set us up for that kind of openness. But I think that's what I'm really pushing for. Even someone like, just people with like, because gosh, this is another off topic a little bit, but some people have a lot of misdiagnoses. I've seen a lot of older Black men with schizophrenia diagnoses, and I'm like, why do they get this diagnosis, right? What's going on? And I see that on the charts, and you can see how that impacts people sometimes. So I've actually had some situations where we kind of had to kind of correct charts, to be honest with you, kind of go to that extreme, because it's like it can be really problematic. So, I mean, the larger points, we just got to educate the younger folks to get a much broader perspective, and the people in practice now, much broader perspective on these issues. Because our system, we've got the results we have, and obviously our system has not worked as well as we should, so we have to do better.
So we have to end now.
Okay.
We have another meeting with Dr. Tweedy and the residents right after this. So the residents look forward to that. And please join me and thanks once again to Dr. Damon.
Thanks again.